This 50-year-old woman was referred for management of oriental cholangiohepatitis. She has had a history of recurrent episodes of cholangitis and has undergone a series of ERCPs in an attempt to remove her multiple stones. Since the bulk of her refractory stone disease is present in her left biliary system, as seen in this CT scan, a decision was made to proceed with a left hepatectomy. This image, however, revealed this one right-sided stone with upstream duct obstruction. She was referred, therefore, in the preoperative period for removal of the stone by ERCP and cholecystoscopy. A selective right-sided cholangiogram demonstrates filling of a branch of the right main duct, above which is a filling defect. A slow-motion repeat of that sequence shows that the takeoff of the side branch is significantly strictured, a finding commonly seen with oriental cholangiohepatitis. A balloon catheter is passed into this ductal system. This injection further delineates the extent of dilation in this subsystem. The stone is more clearly seen and appears to be a 6 to 8 millimeter stone in diameter. In order to access this area, a dilating balloon is passed up through the stenosis and over the wire. As the balloon is expanded to its full 8 millimeter diameter, the waist of the stenosis can be observed to expand to obliteration. The balloon assembly is then removed, and the cholecystoscope is advanced into the area. The scope visualizes the recently dilated stenosis, which is puckered and slightly edematous. In order to facilitate scope passage into the correct duct, a guide wire is passed under direct visual and fluoroscopic observation. Once the wire is in place, the scope can then gently be nudged through the stenosis and over the wire and up into this area. The entire region can then be inspected. The mucosa in these ducts appears to be normal without additional stricturing or suggestion of mass. The single stone is easily identified. While this stone could be trapped in a basket under direct visualization, it may be too large to pull down through the stenosis. Therefore, stone fragmentation using EHL is performed. This proceeds quickly as these stones tend to be soft. These fragments can then be flushed out. A follow-up CT scan performed 2 months later after the left hepatectomy demonstrate that this right-sided ductal system remains decompressed and free of stone disease. Management options in patients with refractory stone disease and oriental cholangiohepatitis include a spectrum of surgical, fluoroscopic, and endoscopic approaches. Surgical approaches include the creation of a roux on Y limb to improve drainage, or a pouch or stoma to provide easier cutaneous access to the bile ducts, or, finally, as in this case, left hepatectomy to excise the most severely affected portion of the liver. Radiology colleagues can percutaneously access the affected biliary tree either through the liver or a surgically created pouch to remove stones and dilate strictures. Finally, through the use of fine caliber cholangioscopes, endoscopists can successfully assist in removing stone burden and dilating strictures in these patients entering the biliary tree through either a percutaneous or peroral route. There are no controlled data comparing these approaches, but in one series, left hepatectomy with endoscopic management of the left-sided disease had been associated with long-term benefit. Also, by removing the area most affected by the process, some may benefit in cholangiocarcinoma risk reduction, which overall seems to be as high as 5 to 10% in affected patients over their lifetime.